What's up, everybody? Welcome to another episode. What we're going to do today is introduce you to one of my mentors, Josh Park. We're in his clinic, MOCEAN PT, which is going to be in Manhattan on 42nd and Madison. He's someone that I look up to, someone that I really go to for advice, especially about PRI. It's something that we get a lot of questions about, so we wanted to kind of get in here and do a little bit of interview. We're also going to take you through a little bit of an assessment where he's going to assess me and kind of go into some detail on why we do these things and kind of the thought process behind them. But first, let's have me turn it over to Josh and just let him introduce himself. So why don't you go ahead and tell us about the clinic, what do you guys do here, and really anything else that you want to share.
Hi, my name is Joshua Park. I'm a physical therapist and I'm the owner of the MOCEAN Physical Therapy Clinic. So our system, our main frame of the system is a PRI-based clinic, and we use a lot of PRI objective tests for the patient assessment. But what we wanted to create is more than just a PRI. We wanted to create the data that's objectively scalable. That's why we have all this system. For instance, we have this X-body, which shows up analysis of the patient, the external skeletal structure, so that we can see how this person is, how much imbalance or asymmetry this person has. And also to assess the internal cellular health, we have a InBody 770, which is a medical grade of the body composition analyzer. It shows your fluid level, like muscle, like weight and fat tissue level, and then most importantly, the inflammation. And lastly, we have one more main test that we do, which is a stress test of the autonomic nervous system by assessing heart rate variability. Based on that, we see whether this person is in the state of a sympathetic or parasympathetic system. And along with all this objective data, we go into the PRI, the measurement, and then we set the personalized care system for each individual.
Awesome. Yeah, and I was actually able to go through that stuff, which is really, really cool. I actually did really well on the stress test, which I was pretty happy about. So it was really cool to see all this stuff. And if you're coming to New York, I highly suggest definitely checking it out. So in terms of the PRI, what are some of the kind of the questions that I get asked a lot, or even just what are some of the light bulb moments that you had? What are some of the things that PRI does that really stand out against other systems?
So one thing that PRI stands out is for sensory awareness by feeling, sensing the reference points. Nowadays, a lot of PT, like physical therapists, whether it's a physical therapist or the personal trainers or any trainers, there are so many systems out there and really looking really cool moves, but it's really at the end, it's not about the movement, what kind of style, but it's how much this person, the client or patient, be able to sense what they're doing. And what PRI helped me the most is to be able to find those reference points and shift the patient into that point and be able to still move the same thing without losing those contexts, so that the person can fully facilitate whatever muscle chain and the neural chains that needs to be facilitated, and whatever that's needs to be inhibited can be shut down.
Nice. Yeah, and that was really cool. One of the things that we actually did together when I first came here was actually looking at my jaw. So something that you totally wouldn't even think about is the idea that maybe the bottom part of my jaw was actually pulled back so that I had the overbite. So we already started working on kind of bringing that together. So it's really, when people even think about neutral spine, it's crazy to think about how much that continuum actually goes to even thinking about, your jaw, the way that your skull is centered, everything across the line. So what would be some of the reference points that you see people often missing? I think one of them would be kind of your left heel is something that you commonly see. What are some other things that you commonly see?
So there are 5 main reference points that I assess. One is obviously left heel and right big toe, and also I assess their sit bones, whether they be able to sense a left sit bone versus a right sit bone, and the other one is senses on the fingertips. And people who has a right BC has a lack of sensation on the inner palm on the left side, have a hard time feeling the be able to maintain the left outer the palm. Also, the other one is vision, occlusion, and sinuses, the nasals, and yes.
It's crazy. There's so many levels to it. I can definitely speak firsthand to that. And really what's cool, I think from a training perspective, even if you're not going to get to the level of mastery that he's doing, for example, I don't know how much someone that's just a regular trainer is going to be going into working on someone's jaw or neck, but just to understand that it's actually a big thing that can be a defining factor, and you would have to refer out, but even just being aware of it has been huge for me, and just conceptualizing it. One of the other things that's happened a ton for myself is while Josh is talking about some of these things, I'm visualizing clients that I've seen with these issues where they're not able to get that pressure there and they're stuck on the side and their wrist is bothering them, or they're always in that knee over there and they're never able to sit back and feel their left hamstring. So that's one of the things that actually drew me to PRI and started asking and looking for mentorship from people like Josh, because these things have come up so much that I couldn't ignore them anymore. And then I found that he was able to articulate why they're happening. And there's a whole entire system of, I can't even count how many courses that you've done on that. So it's really cool to see that all come full circle. So why don't we actually just go ahead and get into the table testing? We'll kind of go through that, and that way I'll ask you some questions and we'll get into detail on that. Sound good?
Sure.
Awesome.
Hi guys, so I'm going to show you guys the 5 or 6 the assessment the PRI assessment that I use to everyone, whether the patient coming with a neck pain, shoulder pain, foot pain, whatever pain it is. I just do this 5, 6 tests to everyone to see what kind of pattern this person is stuck into. First thing that we're going to test is a straight leg raise. Okay? So the right side, I stop when I start to feel the first resistance, and right side, he has no issue. Yeah. And when I go on the left side, as soon as I start right here, do you feel the resistance? Yes. So, about 45 degrees, there's a resistance. And second test from the same position. So, keep shoulder and the elbow 90 degrees. And right around here. Feel the restriction. Okay. And then, same position, we do. Could you scoot over towards me a little bit? Right there. Good. And then, external rotation, right around here. Okay. And then, can you come towards me? Okay. And horizontal abduction on this side. You're gonna see all this. Okay, right here. Okay. And then, let's check the other side. So we're gonna start with the horizontal abduction first. We're gonna check, relax. Right around here. I start to feel some tension in here. Okay? And then, go ahead, scoot over. Okay. Actually, can you scoot over a little more? Right there. So, horizontal, internal rotation is no problem. But when we do external rotation, this is where I start to feel the restriction. Do you feel the restriction? Mm-hmm. Okay. And then the next test, I want to do an over test. So could you scoot over the inside? Turn around. Good. So keep your hips, knees. Can you come towards me a little more? Perfect. And then put your hand under your head. Perfect. Scoot over right there. Relax. Relax. So, based on all the assessment that we did, he's in the typical the left AIC. But this over test, when we do it, it blocked everything. It comes out as a negative. What does that indicate? I know. Let's actually test the right side. The right side, block it, relax. Yes, both side is negative. So if his body everything was neutral and this is a negative, that's a good sign. But all other signs shows he has a typical left AIC pattern. But the left adduction drop test, over test, was negative. That indicates his hip ligaments has been compromised from, I don't want to, I love FRC stuff, but the limitation that I see in the FRC, they emphasize so much on the end range cars, but they don't understand the putting the pelvis into the right position. Meaning they can do all the hip cars, IR, ER, but if the pelvis is not in the right position, what's gonna happen? They have to compromise something for him, which is a hip ligament, has been compromised. So everything on his hip capsule got a little loosened up. That's why his adduction drop test came out to be a negative. In the case like Ian, who has compromised the ligaments, in PRI, we call this term called the ligamentous muscle, meaning muscles that holds the internal and external rotation needs to be strengthened more than other people, so that the muscles can act like ligaments to hold the hip, the femur into the acetabulum in the right place. Okay, all right. So let's have you lie on your back. Now we know he has a limited single leg raise on the left side, internal rotation limitation on the right side, limited horizontal abduction on the left side. And next thing we have to check is whether this is a mechanical tension, which means whether this muscle got tight from the overuse, or is it neurological tension. The easy way to assess is by using a color lens. So cranial nerve, ocular nerve is so powerful the way we perceive the world through our eyes. So by we just changing the colors in the eyes, the brain accept it as and then whether it's upregulate or downregulate the sympathetic or parasympathetic system. So we're going to use is a purple lens. And we're gonna do the exactly same test and see if the test result is changing, okay? So can you bend your knees? Perfect. So first, actually, could you scoot over a little more? This side. Perfect. So first thing we're gonna test is IR. So before and now, be able to go all the way down, and to make sure shoulder and elbow is in the same level. Then we go down. There's no resistance at all. Do you feel anything? Nothing. Okay. Now, this was already fine, but let's go back to the other side. So let's check his left ER. Before the lens, I was able to feel the restriction right around here, but with the lens, relax. Let me know when you start to feel the restriction.
I can feel it there a little bit.
Yeah, right there. Okay. And then let's check the abduction. Can you come towards me? Right there. Relax. Can you see the abduction drop significantly improved just by a lens? Okay. And let's go back to center. Let's check his single leg raise. So before the lens, before the glasses, I felt the tension right around here, but I don't feel anything right now. And let me know when you start to feel it.
Let me feel it there.
Yeah, so right there. So just by putting the lens, his range of motion significantly improved. But this one is not the treatment. We just wanted to confirm whether this person has a neurological tension or mechanical or muscular tension. Obviously, Ian has a neurological tension. And we can use so many different ways to assess whether it's a neurological or muscular. So, Ian, can you take the glasses off? So with the typical left AIC pattern, we say one side is stronger than the other. And in terms of the ocular, in the typical left AIC pattern, our right orbital is way more hyperactive than the left side. So we're going to block his right eye to inhibit his right ocular, so that we can inhibit his left brain, so that he can maximize or facilitate the right brain activity. So can you just put this right now?
And thinking about inhibit is just another way of saying like shutting off, right?
Yes.
Down regulating.
Down regulate. Perfect. Yep, exactly. And then lift your butt. Now just by blocking his right eye. Relax. Some people say, this is all like BS, So what we're going to do is we're gonna block his left eyes and see if anything changes. So what we did by blocking his left eyes, we just make it left AIC pattern more dominant. Right here. Do you feel it? It got even worse because we just upregulated his pattern. So some people think it's all gimmick, but this is a power of the neurology. Just by able to shutting up the one reference points and facilitate the other side, our neurological tension just changes instantly. So this again is not the treatment. Now from this we have to go to what is the root of this cause. What is a neurological tension? For him, definitely it's not a rib cage. If his rib cage was externally rotated and he had a wide ZOA, then we will say we need to work on his breathing, open up the posterior mediastinum and posterior pelvic tilt, engage the hamstring. But as you can see from his ISA angle, this is pretty perfect, like 90-degree angle, right? This is perfect. So it's definitely not the breathing issue. So then, when I saw Ian, one thing that I noticed is that he has, if you look at his chin is slightly protruded. That means, can you open up your mouth and bite your teeth? And if you look at it, can you get a little closer?
Let me take this off too.
He has the open bite, meaning the front teeth, top teeth, is not touching the bottom teeth of the bottom teeth. That's why what's happening is his brain is trying so hard to find the ground. When we think about the grounding, we think about only from the feet. But the reality is, in order to feel the ground, we need to first sense what's on the teeth. Ian's jaw. So if you look at Ian's jaw, the mandible teeth are protruded, meaning he has an open bite from if you look at it from the bottom to top view. Because his teeth are not touching each other, his body is trying everything to tensing up to feel the ground, to sense their teeth occlusion. So what we're going to do, his treatment is to focus on restoring the position of the jaw by restoring his cervical spine. Then all this rib cage, all this things that he does it can the performance can be maximized. So this is just a mouth guard that you can get it from the Amazon for like $5. I'm going to just put this under his mandible. So point of putting this mandible, the mouth guard, is just like orthotics. We put it on the foot so that the in can sense, his brain can sense like a occlusion between top teeth and the bottom teeth, so that his body can relax, so that all the neurological tension can be inhibited, down regulated. So now having the mouth guard, what I want you to do is glide. Don't chew hard. I just want you to sense and just slightly glide so that your bottom teeth is touching slightly on the top back teeth. Can you feel that? Mm-hmm. Good. And then can you bend your knees? And can you come towards me? Good. Now we're going to assess right there. Once we understand his work, what kind of pattern he is, we don't have to go through the whole 5 assessments. We can just choose 1 or 2 to see if we made any changes. And we're just using this left side. And what do you feel? Good. Relax. So we used this to assess if the Ian's tension was a neurological, and we confirmed. And then next thing we had to find what is a root, and we saw his rib cage was perfect, and his root was actually coming from the jaw. So treatment or the exercise will be focusing on restoring the position of the mandible and position of the cervical spine, so everything can be down regulated.
I was asked, one of my questions was to ask, what muscles do I need to focus on to feel them move to get to that position? But the whole point of, and one of the big principles of PRI is not thinking about the muscles, the movement, or the action, but more so just letting the position dictate the function. So where it's, instead of thinking I need to feel this muscle, I need to do that, it's more about when you get to the position, the thinking doesn't have to be done anymore because the position will facilitate the function that we're after. So it's kind of in a way playing chess versus checkers, right?
Yes.
So once we get you in, the right stuff happens because you're in the right position.
Exactly.
And that's why it's what you've been learning and using is and making it in a way more elementary or more of a prerequisite to FRC is, can you get into the right position first before I try to stretch you into a position or even try to control something that you can't even really get into, right?
100%.
So that kind of ties it all together. So in terms of any other exercises that I would do, is there anything besides the jaw? Or would I maybe do some left hamstring?
Yes. So for him, in order to feel the occlusion from the teeth, first his brain needs to understand what is going on in his feet. So always I start with a 90-90. Whether the person has a neck pain, shoulder pain, again, any pain, if the person is stuck in the left AIC, always start with the supine 90-90. But as we progress, we have to get up to the jaw so that the jaw position can be maintained.
And you would want me to do a lot of my exercises, especially we even talked about the idea that I like to do this, and that it would almost be detrimental to do that with my bottom pulling back further than my top, because that would reinforce the pattern we're trying to change. So we talked about a compromise of maybe if I wanted to work on that, it would have to be with this so that while I'm changing the position of my neck, my jaw is still staying with the sense of staying alive.
Yes.
And I could also do my breathing drills with this, which would help.
Yes.
Which would technically open up the airway, right? Because the bottom of my jaw pulling back is what's closing the airway more. Does that make sense?
Yes.
And then for my 90-90 left hamstring bridge, would you say that my next one would be a right glute max?
Yes.
And then it would go to left adductor?
And then for you, specifically for you, when you do 90-90, a lot of the fitness industry, when you do a lot of heavy weight lifting, people emphasize on the chin tuck, right? But people say forehead posture is bad, right? But not many people know that chin tuck also is sometimes it's even worse than the forehead posture, because whether you're doing a forehead posture or doing a chin tuck, you're compromising cervical spine, the lordotic curve of the cervical spine. Now, by him sensing the teeth coming forward, be able to protrude the mandible, we're opening and we're inhibiting his the muscles that's pulling his jaw, right? And then next thing, we have to keep his cervical spine like lordotic curve so that he can get the full airway. So I'm gonna roll up the towel. So when people do like my patient, a lot of the people, when they make the mistake is that when they do lift their hip, they tend to do chin tuck as well because they're so used to doing this. But what I say, you have to keep this, don't compress this towel. You have to keep this towel lifting your cervical spine, not instead of you pressing down. Okay. So in this position, breathe in. And let's breathe out. Drag your feet down to feel your left. Perfect. Right there. Now I want you to be nice. So don't press this one. I want you to keep this chin up a little more. Up. Chin is pointing up in the ceiling. Go. 3, 2, 1. And slowly breathe in. As you breathe out, I want you to lift your right foot off the wall. Right there. Now, by just maintaining this position, his brain understands from the contact on the surface of the foot to contact on the surface of the teeth. Full connection from the bottom to top. This will open up his airway and he's gonna down-regulate his tension and he will be in the good shape after this. And relax. Yes.
Yeah, let's feel that.
What did you notice anything with this?
I mean, I could definitely get into the hamstring really well. Not that I couldn't before, but I could definitely feel it even more. When you're cueing that, are you cueing any inside or outside of the heel?
Oh, yes. So this time, I wasn't telling him to feel the outer side because he already knew. But if anyone who like have no sensory awareness, I will cue him to sense the left outer heel so that they can get feel the like arch of the left foot can be coming up by sensing this.
And would I want to keep my knee in, right? I wouldn't want this.
Yes.
So I still want adductor, a little bit of adductor.
Yes. So just by having some sort of the ball in between, that will have him be able to sense the inner thigh. Again, the ball is there so that his inner thigh can sense the surface.
And what about here and then here? Overkill? Too much?
I mean, if you can
for
do it,
now.
yeah. So
Yeah.
people like Ian, he's in good shape. And now because he has a sensory awareness on the occlusion, his body can do so PRI, I want to say, it's a principle, you know. Once you understand the principle and understand the sensory reference, then you can just utilize this concept in any activity. You know?
And the reason that I asked that would be because, and correct me if I'm wrong, if I reach in this direction, it'll help me find left oblique,
Yes.
which is often missing in left AIC.
Uh-huh.
If I externally rotate here, it will open up these ribs to facilitate apical expansion,
Yes.
or the upward expansion of my right lung, which in that pattern is usually brick down. Okay.
But for him, the reason it wasn't really necessary for you, because you already had a perfect rib cage position. So again, your issue was the over-dominant left brain activity, not the air chamber. So once we just down-regulate the activity on the left lobe, your body just went right into a perfect symmetry.
Perfect. That makes sense. Thanks for watching. Hopefully you've learned a few things. In terms of finding out more about this stuff, the first thing that I want you to do is reach out to Josh. So we're gonna put his information up so that you can find him on Instagram, follow him. Unbelievably really nice. So just reach out to him. He wants to hear from you guys, right? And definitely come see the clinic when you're in Manhattan. We'll put all the information up there. The second resource, which he'll also direct you to after, because he can't teach you a whole course anyway, is to go to PRI and learn more about this stuff. And if you have any questions at all that I can help answer, ask me, but I might just send you the guy that I'm learning from anyway. So anything else that you want to add, Josh?
Thank you for coming.
Absolutely. Enjoy the rest of your day, and we hope to see you next time.